Hello everyone, I'm Alex Psirides. For those of you who don't know me, I am the clinical lead for the National Patient Deterioration Program, Deteriorating Patient Program, and I'm also an intensivist in Wellington Hospital as well. Can everyone hear okay? Because you're all on mute. Excellent, good to see, thumbs up all round. So I've been asked to give this talk essentially to try and clarify what is a difficult area, because there's no right answer, but there's lots of wrong ways of doing this. Now, all I'm going to give you mostly is opinion, because it's a relatively evidence-free zone, but it's something that has come up a number of times and sufficiently to the point that we're trying to address it directly. So I'm going to give you what I think are good ideas. There's some guidance in the vital signs user chart, vital signs chart user guidance that we've put out, but not huge amounts. And there's a deliberate reason for that, which is that people are entitled to do it however they want. But I'm also going to speak briefly about the rationale behind why you may need modifications, because it's not immediately apparent. And I'm presuming what will be questions that you've all faced from clinicians in your hospital about why we're changing things. And I'm also going to talk about probably the easier way of how you shouldn't change things. So a lot of this is opinion, which is backed up by experience rather than necessarily hard facts and references and papers. But where I'm making evidence-based assertions, I've included the references on the slides. The slides will also be available independently, so don't feel you have to write anything down from here. I'll put them in a PDF and give them to Emma, and we'll put them on the website. So we should begin, assuming my slides advance, with this. So this, of course, is the New Zealand Early Warning Score. This is what we're talking about, and hopefully you're all familiar with it with regards to the bandings and the separate scores. And what I wanted to do was to represent it in a slightly different way, which is how this is divided amongst the population. So at the top, you're familiar with white in the middle, and as we move from where most people are sitting in the middle and they get sicker, they move through different bands. So this is just a normal distribution curve showing where most people are somewhere in the middle. And I'm going to show you some real-time data from Christchurch that supports the fact that most people are actually fine. As you move further away from the big band in the middle, people get sicker. Their physiology gets more abnormal, which means their early warning score goes up. I'm also going to show you some calibration data that shows you what a high early warning score looks like in terms of being dead. So it's fair to say the more abnormal your physiology is, then the more chance you have of ending up dead, which of course is a bad thing, and that's why we're all here. Now, what modifications do is essentially shift the shape of this curve, and they shift what's visible with regard to nurses taking vital signs and escalating and doctors responding. So I want to talk firstly about vital signs, because that's the basis of where we're coming from. And for those DHBs I've visited, I've talked about some of this before, but I want to go into it in just a little bit more detail. There's a variety of papers that are very useful when it comes to talking about vital signs, and there's a lot of debate goes on around why we even bother doing vital signs. Literally, vital signs is derived from vitae, meaning life. So they are literally the signs of life. And there are a few debates about what actually constitutes vital signs. Now, there's a core group that obviously are included in the New Zealand Early Warning Score, but before we had oxygen saturation available at the bedside, that obviously wasn't available. And as you know, we've added oxygen delivery because it's associated with the risk of increased death. But this is probably the paper that at least started a lot of people thinking about this, and it only became about because of the ability to collect ridiculous amounts of data that you could never collect by hand with the advent of electronic capture of vital signs. And for those of you who haven't read this paper, it's from hospitals across the US. It's for 1.15 million vital signs, the absolute size of which is mind-boggling, and probably 20 years ago would not have been possible. 42,430 admissions on 27,000 patients over an 18-month period. And what they did, because they had outcome-linked data, was that they plotted the vital sign and then plotted the mortality. Now, because it's an American paper, they used the slightly quaint term expired on the y-axis. Expired means dead. It doesn't mean breathed out. So just to clarify quite an important point. So when they say expired, they mean dead people. So if you look at the y-axis on the left, this is the percentage of people who died. And the y-axis on the right is the number of admissions for which that vital sign recording was prevalent. And on the x-axis, for this particular graph, which is systolic blood pressure, you can see those values. So what you can see for each vital sign I'm going to show you is the prevalence of normality, which is the line that goes through the middle of the curve. So you can see if we take, for example, 100 to 160, that line peaks, and that is about 45,000 approximately admissions had that blood pressure. And if you had a blood pressure in that range, it was associated with, you can look at the black bar, a mortality of about 3%, which is about the hospital mortality. What you can also see is the further you move from normal to either side, then the higher your chance of death. But fortunately, what also happens is the prevalence of that blood pressure decreases as well. If everyone in the normal range had a 25% chance of death, then that would be a very bad thing. So you can see that most of the graphs I'm going to show you end up with the prevalence in the middle and the mortality increasing either side. It also, most of them follow this kind of U-shaped distribution where too low is too bad and too high is too bad. And I'm always reminded of the Goldilocks porridge story, that just about right is exactly just about right. So the lower your blood pressure, the more chance you have of dying. Perhaps not surprisingly, if you have a systolic of 50 to 55 during this admission, you have a 23% chance of not surviving this admission. And all the way up to, obviously, hypertension is worse than hypotension. So for every vital sign, you can validate them in terms of why we do them. And the simple answer is we do them to spot bad things happening, i.e. people dying. And for every parameter, they have graphed these separately. So this is the graph for respiratory rate. Tachypnea is worse than bradypnea. And you can see for the normal range, somewhere between 14 to 28 accounts for a significant proportion of people. And then once you get to a respiratory rate of 4 or less, your mortality is 12%. We have the same thing for heart rate. Tachycardia is worse than bradycardia. Obviously, a variety of reasons: sepsis, tachycardia, hemorrhage, tachycardia. Bradycardia is probably heart blocks, but there may be other things as well, including overdoses, beta blockers, etc. But you can also see there's clearly a tail towards the right where tachycardia is worse than bradycardia. With saturation, obviously, it's skewed to the left because you can't have sats of more than 100. And the more hypoxic you are, the more chance you have of being dead. And you can see once you reach sort of anything below 85%, your mortality sits around 8 to 10%. And finally, from these at least, probably not surprisingly for Glasgow Coma Score, if you have a GCS of 3, i.e. are comatose at any point during your admission, it's associated with a 1 in 2 chance of you dying. So that's not too surprising, and you can see that's clearly skewed to the left. You can also see from the single line that most patients were GCS 14 or 15, which is fortunate. Not many were GCS 3. So that leads us to the point where we can now validate what's normal and what's abnormal. And this is the summary data from this study. Your mortality for critically abnormal vital signs, which they define within the paper, is 0.92% for a solitary parameter. But if you have 3 simultaneous critically abnormal parameters, the chance of you dying is 1 in 4. And what's also of interest and informed our policy around what our frequency of vital sign monitoring was that of those with 3 simultaneously bad signs, only 1 of 4 did so within 24 hours of admission. So 3/4 of patients are deteriorating beyond the first day. And that's where the bad things are happening. So these aren't people necessarily who are being admitted and getting worse early on. These are people who've been in hospital for more than 24 hours. And that's associated with a higher risk of death. So just coming back to something that we talked about before, certainly during the grand rounds, which is how we actually ended up with the New Zealand early warning score. So the first paper I've just shown you is showing you that abnormal is bad. The second paper tries to quantify just how bad abnormal is and where we should draw the arbitrary lines on our charts and how we should assign our scores. And this is the paper from Resuscitation from 2010 that essentially led to the UK National Early Warning Score that, as you know, we've modified and added metformin parameters around. So this compared 34 different early warning score systems. Now the statistical stuff is a little complex, and you'll see at the top left there is the acronym AUROC. But what this essentially is representing is what's called the area under the receiver operating curve. And without boring you with stats, because I don't completely understand it myself, essentially the higher the number, the more sensitive and more specific your system is. So the better the system is at detecting sick people and not falsely triggering for people who aren't sick. And this is calibrated on a mortality, i.e. chance of being dead. And you can see for the different bars on the left-hand side, those indicators, that's the time within which patients are dead from a given early warning score. So what this graph does is compare 34 different early warning score systems that have been published in the literature prior to 2010. They took a data set of 200,000 patients, 200,000 vital signs that was index linked, and they ran these through all the different early warning scores in existence. And what they found was that the views, as it was then called, was the best predictor of death within 12 hours, 24 hours, 48 hours, 72 hours, 96 hours, and 120 hours. Because as you can see, all those dots are higher than any other scoring system. And it's the closest to 1, which is the perfect system that you're going to get. And this is a standard means by which you compare and contrast sensitivity and specificity of systems to make sure you catch all the right patients and don't catch any of the wrong patients. So you want it as sensitive and specific as possible. So this still remains, to date, the only evidence supporting the choice of the New Zealand Early Warning Score as the most sensitive and most specific early warning score system in existence. There's been no paper published subsequent to this that shows any difference, which is important because what we've come to you with from the start is an evidence-based argument for why whatever system you were using should be changed to the best system, which is secondary to the argument of the fact that everyone in New Zealand should be using the same system, which is the only evidence-based system. So prior to us coming along with our fancy charts and saying, please could you change, whatever system you were using was probably one of the other 33, unless you already moved to the UK system, which we had in Wellington and our surrounding hospitals. This graph and the next chart are the ones that seem to cause the most interest for reasons I'll explain. This is for the vital signs of almost, you can see, n equals 200,000 people. Sorry, I should say n equals 200,000 data sets. I don't know the number of patients. This is the number of data sets they had. The black bar is the percentage of observations at that score, and the line is the percentage mortality associated with that score. So what you can see again, as I've just shown you on the previous paper, is that towards the left, with lower scores, there are more people, but as your score gets higher, your mortality rises quite quickly. Now, what I've done was to take this graph and turn it into numbers that give us some idea as to where we sit. And this is important because we've used this to refute a lot of suggestions that the New Zealand Early Warning Score is going to create all this work for us, because all of a sudden we're going to find all these sick people. And we used this and considered it carefully before we tried to break your hospital. So what we have on the left is the New Zealand Early Warning Score banding. From that data, we have percentage of patients within that range. And then the numbers on the right-hand side are the percentage mortality within 24 hours of that score. What we then equated that to was a general comment around what's likely wrong with them and how we came up with the banding. So I'm going to focus on the mortality and also the New Zealand Early Warning Score patients. So you can see most patients have a score between 1 and 5. That's 60% of all patients. 27% of patients in this data set had a score of 0, and that's associated with less than 1% being dead within 24 hours of that score. By the time you reach the blue score, so that's 10 to 16, you have between a 9 and 43% chance of being dead within 24 hours. So if your score is 16, you could flip a coin, and whether you're dead or not will be determined by whether you get heads or tails. So it's almost a 1 in 2 chance of you dying. But also, probably reassuringly, you can see that only 2.2% of patients are actually covered by that. So from the escalation criteria, if you add all these up, 95% of patients score 7 or less. So there's a number of people that you can work out when you draw your escalation pathway to sit in there to determine what you're going to do. So this was theoretical. This was based on the UK paper from their analysis. And I'm extremely pleased to say that my very good friend John Hewitt down in Canterbury, using their data, sent me this last week, which beautifully identifies what's actually happening in a live New Zealand population in a tertiary hospital. So John's very kindly agreed for me to share this. As you're probably aware, Canterbury has had patient track introduced as their vital sign electronic capture system for a while now, and they implemented the New Zealand Early Warning Score a while back. So this is John's daily set. You can see along the bottom that runs from the 3rd of February this year up until 2 weeks ago, the 13th of July. And each bar, each vertical column rather, is 1 day. And they're gathering about 3,500 early warning score sets per day. Now the grey bar at the top has to be grey so you can see it. It's actually equates to the white zone on the chart. And the yellow bars equate to the yellow zone on the chart. If you then look down, there's a small orange, then there's some red, and at the bottom you can just make out there's some tiny little blue marks, which will be, I can see we're leaning in to look closer to the screen. So there's no way to make this any bigger, unfortunately, otherwise you lose the quality of the data. But what you can see here, reassuringly, is actually when we apply the New Zealand Early Warning Score to a New Zealand population, there's less than the UK population found when they were actually giving us the yellow, orange, red banding. So reassuringly, at least in one DHB, I haven't broken it by suggesting that you use the New Zealand Early Warning Score. Now, your experiences may vary, and I'm looking forward to working with Whiter Mata as well as with Middlemore, who have now come online with these systems, and I know certainly North Shore has had this for a while, to try and collate data across the country. There's a whole lot of other stuff we need to get out of the way, including getting ethics permission to access this anonymously. But you can see so far across the country, at least in one tertiary hospital, the vast majority of people are scoring in the white zone, which is grey here, and in the yellow zone. And you can see that the red doesn't really start kicking in until you get to about 5%, which is a total of the red and the orange and the blue together. So most people are sitting in zones where they have a low level of illness and will not require mandatory escalation. Now, when you come to modifications, this is taken from the Waikato chart, from the ADS score. There's a whole variety of different ways of doing this. Now, when we came to design the modifications box on the chart, looked at a variety of different ways and trying to work out what we thought was the best one to recommend. And although this is pretty, it takes up a lot of room, we thought this was probably too complex. Now, not to say this is wrong, but you can see here you have the ability to shift scores either way. You have to give a clinical reason, which we thought was an excellent idea, so we stole it. And this is one way of doing what we eventually ended up recommended doing. But the feeling of the experts who looked at this was probably it was a little too complex to use in practice. So this is what we ended up on. This was the result of 12 different drafts, 1.5 years of testing in Cape Coast. And also after the pilot sites used this, was changed from feedback to represent a variety of things. So a few things changed. The first thing was a reason, and I think reason is a very good idea to include. That came from Auckland actually as a feedback, and I'll talk about why later on. There is an anomaly in the QSMs, sorry, in the monitoring trigger that we're asking you to report, which is the role of the person amongst name and contact details, and that's an error on our part, and that's been notified to us. The reason is the original chart said name, role, and contact details. And we subsequently took that out because what we found were different DHBs had different people in different roles. And it was just simpler to have a name and contact details. So we need to amend what we're asking you to report, which Emma's duly writing down, which we will do. And so apologies when we were asking you to audit that. Well spotted, whoever spotted that and sent that in. That was a hangover. I can see you. Excellent, thank you. So that was a hangover from an earlier version of the chart. What we did is we updated the box, but we didn't change the tool. So I apologize for that. What you have at the moment is the vital sign that says use abbreviation that I'll show you in the next slide, accepted value and modified early warning score, the date and time that has been signed off, a duration, which I put hours around arbitrarily, but it doesn't have to be, and then the name and contact details of the individual. And most importantly, a large box at the bottom that has reason. It is deliberately limited to only 3, because the more you modify, the more chance you have of hiding the patient from the safety system, and I'll talk about that a bit later on as well. We didn't want every single parameter to be able to be modified. So actually limiting it to 3 at most was a safety feature as well as a space saving feature. There is also an indication on the bottom if the patient is not for CPR or not for MET, that should be indicated there because that's important when someone comes to do vital signs and they hit a MET criteria and see that the patient is not for MET, then that shouldn't be what happens. There's a part at the top, you can see it explains the EWS can be changed to prevent chronic disease incorrectly triggering escalation, and that was always our primary priority. All modifications must be made in line with hospital policy and regularly reviewed by the primary team. So that allows you to determine in your policy how you want to do this locally. And then in bold, it says ignore any modification that is not signed and dated. Now, to reiterate what I said at the start, this is deliberately open-ended and non-prescriptive. We deliberately haven't told you what it is you have to write in here because we recognize that even within one ward in one hospital, you may have 20 doctors modifying in different ways. But what I'm going to talk about now is what I think are sensible ways of doing this and some really dumb examples that I've seen in my own hospital over a number of years. Now, part of the downside is that being an intensivist, I get to live in an ivory tower where everyone else's dumb modifications come to my unit when they fail. So I can judge all these people who are doing really stupid things. If I do stupid things, no one else finds out apart from the ICU nurses. Who probably have a file on me. But that aside, I get to work out what modifications work and what don't. So what I'm talking about, I guess, is based on experience of where modifications haven't worked because they've ended up coming to my ICU afterwards. So the box that talks about abbreviations, this is just a summary of the bit of the chart. These are the recommended abbreviations, and these are included on the left-hand column of the chart. The idea being that rather than people writing non-standard abbreviations, they can just use the ones on the chart so there's consistency across there. This isn't stated explicitly, but the human factors design of the chart is such that it pushes people towards using the right one. You can see, for example, for heart rate, it says heart rate, BPM, and then it says mark HR, and HR is in bold to accentuate the fact that this is the accepted abbreviation. So now I'm going to talk about why we might modify, and I'm going to break it down into a couple of different ways. So in terms of duration, I think there are probably a couple of ways to look at it. You modify because there are patients for whom abnormal is the normal. So these are the patients who fall outside that big central part of the normal distribution curve. And there's probably a couple of examples. The most common one will be someone on home oxygen. If you're on oxygen at home to keep you normoxic, then it's kind of dumb that when you arrive in hospital, we start scoring you for it. So it is possible to modify someone in an unlimited fashion for the duration of their admission to counter the fact that they're normally on home oxygen. And there's a slide coming in a minute where I'll show you suggestions to how I think that should be done. Also, for the large number of extremely fit triathletes who we regularly admit to our hospitals, who have resting heart rates of 38, then it's also dumb that these people should be escalated when their resting heart rate is 38, and every time someone takes their pulse, they get a MET call. Now, that's obviously a difficult area because you need to know what's normal for the patient. But what I've increasingly found is actually patients are really good at knowing this. And when you ask them, when you take a pulse and it's low, and they say, oh yeah, my GP is always saying that my heart rate's low, then that may be what's normal for them. So if you know they have an abnormality that is normal outside the hospital, it makes sense to limit your modification to that throughout the entire admission, because you're not going to fix what they're already like before they come into hospital. Now, obviously there's provisos around that, because you need to make sure you don't modify something so stupidly that you make their abnormality hidden and make things even worse, because the reason they're in hospital is because they've got something they're being treated for. The other modification is the time-limited one, which is where we recognize that there is a problem. It has been recognized, investigated, and you started treatment, but the physiology has not yet improved. Now, I mean, there's obviously a whole load of examples. This essentially is what hospitals do. We admit people, we find a problem, we investigate, and we treat it. But I know that the minute I start antibiotics on someone with a community-acquired pneumonia, their respiratory rate will not instantly normalize. I know their oxygen sats will not instantly normalize. But I also know there will be a point at which I expect that to have occurred. So it makes sense to modify your calling criteria for the time during which you expect things to get better, after which a reasonable time, if they're still abnormal, then an approach rethinking what you did on them should be considered. For example, if someone is still febrile 3 days after they've had antibiotics, then a normal approach would be to query whether you've actually got them on the right antibiotics. Do they have a resistant organism? Are they tachycardic because something else has happened? Are they having a side effect from the treatment? Is the treatment wrong? And there's a whole series of questions that need to be gone through that shouldn't be stopped because of modifications. Modifications are not there to stop people thinking. They are deliberate interventions that must be thought about with the danger of hiding abnormality. So from a time perspective, with regard to the duration, to me, it makes sense to have time unlimited modifications and time limited ones where you would expect treatment reasonably would call things, would be tolerated for a short period of time. In terms of what you can modify, there's essentially two things. You can modify the trigger, which is adjusting the score to any vital sign parameter by turning it up or down, and by bumping the bars on the chart into different directions. Or you can modify the response. So the trigger stays the same, but rather than, say, calling the registrar, you call the house surgeon. And you can do either of those things if you want to. And again, we're not prescriptive about who does this because we recognize every DHB is different. And your governance group around this and your experts need to decide what works for you locally. In terms of how you actually write things down, again, this is to me what seem to be common sense things. So you need to provide a parameter range and you need to provide an associated modified score. I'm going to show you some examples in a minute that are filled in the boxes. It's really obvious to say that parameters should be exclusive and shouldn't overlap. So the example I've given there, if your heart rate's 100 to 120, scores 1, 120 to 140 scores 2. What happens if your heart rate's 120? It scores both 1 and 2. Now that's just someone not thinking about what they're writing. And of course, where there's an opportunity to score lower, someone will always choose the lower score. Whereas in fact, it may be that the patient's getting worse. Generally speaking, you should avoid less than or greater than signs alone. And the example I've seen regularly, which I've charted below, respiratory rate less than 40, early warning score equals 0. So that means by definition, if your respiratory rate is 2, you score nothing because you've not specified a lower end. So what that should say is respiratory rates 20 to 40, early warning score equals 0. But because people don't tend to think about the other end of the U-shaped distribution I've shown you, then you can end up in these stupid situations where the chart is telling you something that is clearly wrong and clearly dangerous. As we said before on the chart, and I repeat again, all modifications must be signed and dated, and as the chart instructs you, if that is not the case, they should be ignored. And you must have contact details so you can be queried as to what it is that's written on there. So if there's something dumb, then you have the ability to ask the dumb person who wrote it, or the person who wasn't thinking. And it's also worth saying that if you don't specify what parameters you want changed, then everything else remains as listed on the chart. So if you list something to say a respiratory rate of 26, but don't specify what happens above, then the chart, that what normally happens on the chart should happen if your respiratory rate is 27. So you only modify the part you're modifying and everything else applies as per normal. This was really useful, I must say. I bought it from ads. Auckland fed back on it. And the top reason for why we provide a reason is it stops doctors doing dumb things. What it does is it makes us think about why we're changing things, hopefully, because you have to provide a rationale. And the rationale is not, I don't want to be wrong about this anymore. It's because it should be about the patient and an explanation of the pathology that's led you to modify it. It also provides reasoning for other clinicians, so the nurse knows why the doctor wrote that. And certainly for out of hours, the modifying doctor was there during the day, but not at night. You can understand the rationale behind why they did what they did. But also it provides accountability. When you're auditing these charts, you can see why they did it. If there's a reportable event around why escalation didn't occur, then there's a rationale documented at the time. For serious adverse event criteria reports, and God forbid for HGC reports as well, you can see why those goalposts were moved because that person is compelled to provide a reason for why they do it. But I think the most important part is the top version. It stops people doing dumb things because they have to justify what they're doing. And justifying doing a dumb thing is harder than if it's actually a valid physiological thing to do. So here's some examples. These are what some I've made up, some are real. This is what I would use as a time unlimited modification. I put the chart bit down there just to show you what it is that I'm changing. So for example, this is a patient who is on home oxygen and has COPD and who's come in, for example, say with an infective exacerbation. This is a not insignificant number of people admitted to medical wards in hospitals around New Zealand every day. So if they're on home oxygen, say for example, this patient's on 2 litres of home oxygen, then that's their baseline. Now what you would say is that you're allowing them some oxygen to be given up to 4 litres per minute, for which their score would still be 0. And that should continue until discharge. It may be later on you want to modify that down to flow less than or equal to 2 litres per minute. There's a reason there, and the reason is stated on the home oxygen and the amount of oxygen they're on. Similarly, when it comes to oxygen saturation, I've said there that anyone over or equal to 88% should score 0 because their oxygenation is normally low. But if their SATs are 86 to 88, then their early warning score should be 2, which means if their SATs fall below 86, then normal criteria apply, which in this case is the red zone, or if you're worried about them, then you put out a MET call. So both these are conditions the patient has come into hospital with and therefore should attract no score. It is debatable as to whether you want to change the flow to less than or equal to 2 or less than or equal to 4, depending on how far you want to move those goalposts. And I think that is a reasonable thing to discuss. But the nature falls upon the person who's written their name there and put their contact details there. And in terms of duration, you can write whatever you want until discharge, whilst in hospital, until next admission. I've just chosen the phrase until discharge. Your doctors will do whatever they want to do, but that's a time unlimited duration. So here's an example of a time limited duration. This is, for example, a patient who goes into fast AF, who's been started on appropriate therapy, be that potassium, magnesium, amiodarone, digoxin, whatever poison your local hospital prefers, and the accepted values and what the modified early warning score of that is. So you can see normally, if your heart rate was between 90 and 120, for 90s and 100s, you'd score 1. And if you're in the 110s and 120s, you'd score 2. But this is recognizing that someone is in fast AF with treatment started, and it's going to take 24 hours, possibly longer, for that rate control to begin to have effect. And it's fair to review at 24 hours to check, because it either means if they're still in that range, then it may be the treatment you started is not the right treatment, i.e. they're not digoxin responsive and they need beta blockade or whatever. Also, it means that you need to review whether you need to modify those values. If their heart rate is going faster, then normal criteria apply. So if they're over 120, then the early warning score applies, which should be 3 if they're in the 130s. Now, what I've not done here is modify the blood pressure. So if you have someone, for example, with fast AF whose blood pressure is compromised, then the blood pressure score still applies. And that's not an uncommon situation for new AF. They get hypotensive, they have fast AF, and you still want them seen. You've just modified one parameter that provides the hypotension 1 still triggering, which means they get escalated even if their rate is controlled. So you've not completely hidden this patient totally. You've just put in some modification for a lower and upper limit. It's duration limited and there is a clinical rationale. And if poor rate control persists, the modification expires and it gets reviewed again. Here's an example of a modification to a response. Now, not all modifications have to be hiding patients from the system. You are completely able to modify to make sure a patient is escalated at an earlier level. So this is a real patient from my hospital in the last few months, who was a patient who was awaiting cardiac surgery. Our ICU was full, as it always was, and we cancelled cardiac surgery. So this patient had a critical coronary artery disease that was systolic blood pressure dependent. So when their blood pressure got low, they started to get chest pain. So what we did was said directly, if this patient's blood pressure systolic falls below 90, then we need to know about them in ICU. So we escalated earlier to the ICU reg for patients who had blood pressure less, this patient who had blood pressure less than 90, and we made that duration for 72 hours to allow that time to pass, during which hopefully things will be getting better and they would have had their operation. And the justification was patient has critical coronary artery disease awaiting cardiac surgery. So the targets are still there, but what we've done here is rather than less than 90, get a registrar, home team registrar review, we've escalated straight to the ICU registrar. So this is a modified response, but not a modified trigger. So rather than what everyone focuses on, which is to delay calling for help, you could actually escalate higher to a more increased intensive level of support if that's what you thought was relevant to do. Now, this is the part that concerns me, and probably I'm guessing the part that concerns you, which it is quite easy to modify people to death, where the parameters are altered and stopping the system seeing them. And there's a variety of things that may happen. If the patient deteriorates within that modification, then the deterioration may go unnoticed. The nurse may take the vital signs, but because the chart is falsely reassuring them everything is fine, then they don't escalate as they otherwise should do. Escalation subsequently may be delayed, and treatment of whatever that may be delayed because the person who can treat them didn't know about them. So modifications must be part of a treatment plan. You shouldn't do them without a plan around it. There's no point in modifying someone if you're not treating the underlying problem as to why you've done it. And where that happens, you just modify things because you don't want to be called, then obviously you're hiding deterioration without changing their treatment. And there is significant potential to hide the patient from the rapid response system by doing so. But I hope from what you've seen so far, you're relatively convinced that modifications are a necessary part of the system. I just want to show you what that looks like on the graph. So this was the graph I showed you earlier, and this is what I like to think of as the safe zone. And what you have in the middle, you don't have any more vigilance than usual, but as you get sicker, if you're unmodified, then the safe zone makes sure you're escalated to the appropriate person. If you start to modify things, for example, here you've dropped the lower parameter as to whatever it is to MET call only, and in the higher zone you're including the red one. If the patient deteriorates, then you're no longer seeing them. So if you modify, you reduce the safe zone and you put the patient at increased risk because the modification hides them from the system. Now, modifications are a really hard thing to study because until you've got electronic capture of vital signs, there isn't actually good reasons as to, easy ways of gathering hold of this data. Unless you go around and look at everyone's chart and do point prevalence audits, which I know you guys love doing because we ask them to do so many of them, then there's no way to get all this information directly. But here's something that I could find. This actually came out this month in the Canadian Journal of Anesthesia, which was of interest because what it does is it looks at patients who met escalation criteria, but weren't escalated until after an hour after they'd presented with those criteria. This is from 3,133 outreach escalations over 4 years in 2 tertiary Canadian hospitals. And they compared the outcomes with patients who were either escalated immediately as per their protocol, or for whatever reason, mainly no one rang and called for help, they had their escalation delayed by up to an hour. what they found is that escalation that was delayed by over an hour increased your risk of death by 30% and increased your risk of ICU admission by 22%. So the odd ratios are 1.3 and 1.22. So if you delay escalation, at least in this group of people, it increases death by 30%, which makes sense, but it's nice to have some numbers around this. If you're modifying, potentially you're delaying escalation because you've reset where the safety bar is, which means no one find out about them until later. And in 30% of cases, or so you've got 30% more dead people as a result of hiding them. Now, this is the most prominent part, other than the title of the chart, that we deliberately made stand out. It's all caps, so we're shouting on the chart in the top right-hand part so you can all see it. It is as clear as we could possibly be, and we did debate the exact words we were going to use. But what it says is escalate care for any patient you, they, or their family are worried about, regardless of vital signs or early warning scores. Now, that clearly includes modifications as well. So what modifications don't do is they don't override common sense, they don't override clinical acumen, and they do not override professional responsibility for your patient. Although there's, to my knowledge, been no test case, I could imagine in a situation where someone didn't escalate because the modifications told them not to, but the patient was clearly deteriorating, you'd be on fairly shaky ground saying, but I didn't think they needed to because someone told me it was all right. You are still professionally responsible for the care of your patient, even regardless of what some silly doctor may have written on a chart telling you otherwise. And it is a grey area, I admit, but I would suggest that modifications should never, ever replace common sense. As someone once observed, the problem with common sense is it's not that common. Anyway, special circumstances. Here are a few ideas that I've been asked to address directly, because these are things that have come back repeatedly across the country as well as from within my own DHB. So there is a certain trend for anaesthetists to continue to use oxygen during recovery from anaesthesia, even if the patient is not hypoxic. There was at least when I was doing my anaesthetic training, was told that the anaesthetic gases had to be washed out, and they used that word in quotes. And to do so required oxygen to be administered, aiming for SATs of 100% for a period of time. Now, clearly in PACU, that's fine because most post-anaesthetic care units recoveries aren't actually using early warning scores. They're waiting until they go to the ward. But where the patient goes to the ward on oxygen, they're being given oxygen for a reason other than to stop them deteriorating. So the normal criteria by which we're using it, as in we're treating someone who's hypoxic, doesn't apply in this situation. And there's some thinking around whether rendering someone hyperoxic, i.e. high oxygen levels, may provide a buffer for hypoventilation. So this is the same reason we pre-oxygenate people before we intubate them, of course, give them as much oxygen as possible so they've got reserves. And indeed, there are some PCA policies that require supplemental oxygen to be given, which I must admit, personally, I've always thought was wrong because it masks hypoxia, which would be an early sign of someone actually not breathing enough. But I'm aware that some of these do exist. And for this reason alone, some people may want oxygen administered even if the patient isn't hypoxic. So what one hospital had done was if patients left PACU on oxygen, otherwise they would have caused false escalation because they were giving it even though they didn't need it, and had a timed modification on the chart that looked like this, which was any oxygen that was at a flow of less than 4 litres per minute had a score of 0 for a fixed duration of 4 hours. And this was a sticker they made and were applying to the front of the chart to modify the early warning score. Now, the logic of the anaesthetist was if they would still required oxygen after 4 hours, they should be reviewed by the anaesthetist, because it could be they've got atelectasis, it could be they aspirated, there could be a whole lot of other stuff going on that was a concern. So this is one hospital's standard modification around the chart. But what they found, interestingly, was that what significantly reduced was the number of patients leaving PACU on oxygen. Simply by introducing a score for something that wasn't physiologically needed, people just stopped using it. And the amount of oxygen, patients leaving PACU on oxygen, decreased significantly because the ward nurse arrived and said, why is that patient on oxygen? They don't need it, I'm taking it off. Now, that's probably not a bad thing. There's a variety of suggestions now, including the ICU literature, that suggest that hyperoxia may actually be bad for you. And obviously, the COPD Patient Society who have hypoxic drives, in other situations, too much oxygen may be just that, too much, and actually may cause harm. So there's probably a trend towards giving less oxygen, but if you work in a hospital where your PACU is saying, I want to send a patient to a ward on oxygen, I think this is a reasonable negotiated point where you'll have anaesthetists who are stubborn and refuse to change to say, how about we do this? It's time limited. If they need it beyond that point, they should be reviewed by someone who understands complications of anaesthesia. This is something we do in our own ICU. We have patients who are often bed blocked, who've been in ICU for a long time or HDU level care for a long time, who have abnormal vital signs that would otherwise trigger on the ward. And we know things are fine because we've sat there in ICU and watched them. And although it's abnormal, it may not have completely resolved when they leave ICU. It's expected to do so within a reasonable time frame. And because they've been observed and we know they're stable and not deteriorating, they're suitable for discharge to the ward. So here's two examples of a patient with, for example, a community-acquired pneumonia who's been in ICU for 5 days. Again, these are real examples that I used just last week, I think, on a patient I sent to the ward, where a tachycardia we've observed in sinus, we know that it's fine because they've been like that for a number of days, and I put a time limit of criteria around that. I would expect their respiratory rate to slow down over time, but I put that around 24 hours, and I would expect their heart rate to slow down over a slightly longer period of 36 or even 48 hours. And you can see, rather than just wiping the score out completely, I've just moved it slightly. So the score can still see people. You've got an early warning score of 1, an early warning score of 2 for the tachypnea. It's not removed it completely, but it's just moved those slightly to normalize what I know is normal for that patient for the short period of time that we're allowing them to go to a ward and see what happens. And beyond that time period, if that expires, the normal early warning score applies. And I probably want to know if 2 days later, the patient was still tachycardic and tachypneic, and our outreach team would pick them up and see them. The final one, it's fairly obvious to say, but is worth saying, is that if someone is dying, then documenting vital signs on them is of absolutely no benefit to the patient. Hospices do not have ECG monitors for a good reason. You don't need one, because if you're dying, there is no point in writing down vital signs. So there may be a reliance on vital signs to tell you what's happening to the patient, but most palliative care physicians will tell you that actually using objective vital signs are probably nowhere near as good as subjective clinical assessment. And if the patient is dying, then what I would suggest you should do is the following, which is to stop all vital sign monitoring. The duration, you can write what you want. Until death probably sounds a bit too final, but forever, if the patient is indeed dying, this is their only admission, so you could write this admission, or however you want to word it. But the justification is the patient is dying and on the palliative pathway. So that would be my suggestion for modifying early warning scores by simply just not doing vital signs that triggers early warning scores. Now that clearly means if the patient is distressed and the nurse needs help, they're not prevented from putting out MET calls. If someone is dying and they can't control their symptoms, be it pain, agitation, hypoxia, then it's perfectly able to escalate. It just means they're not following a mandatory escalation pathway that is not designed for dying people. It's designed for people with recoverable illness. So a few danger things to look out for. The first one is that if you're modifying 2 or more parameters, then clearly you are significantly moving the goalposts. If you're modifying extremely on single parameters, you are also hiding the patient. And generally where I see this, it's where someone has done something dumb because they just want the patient hidden. And in fact, the patient should probably have been escalated to HDU or ICU level care. They should also, probably more importantly, only be performed by someone who knows what they're doing. I know that sounds obvious, but sending in a PGY1 house officer to modify someone's heart rate to 190 is a really silly thing to do. They don't understand the implications, and from what I've just shown you from those graphs, for example, a heart rate of 190 is associated with a significant risk of mortality, and a junior, very junior doctor should not be making those decisions. It's okay if it's delegated, but you need to decide within your DHB what's right for you with regard to who can and can't make modifications. Within our hospital, it's registrars and consultants only who can make modifications. This is unfortunately a real modification. This is a patient who I attended a MET call and intubated them because they were so exhausted. They had had their respiratory rate modified to 70, below which it scored nothing. The patient was breathing at 72 and had been for 4 hours. Now, we could try this as an exercise now. Let's all see how long we can breathe with a rest rate of 72. I actually tried this when I saw the patient, and I got lightheaded after about 90 seconds. And the reason they gave it was the patient had DKA, which they did, and this was compensating by blowing off CO2. But what actually happened was the patient got so tired they had a respiratory arrest and needed emergent intubation. This was actually done by a consultant. So senior doctors are not immune from doing dumb things. But I would suggest when you see things like this, you need a governance process and audit process around capturing things like this that are clearly so stupid that no peer review would ever agree that this was a sensible thing to do. And you as individuals can't necessarily raise this with the individual concerned, because in this case, it was a senior doctor. But what you do need is a mechanism within your DHB to deal with outliers and dumb modifications. And the way this was dealt with was a one-on-one conversation with myself and the individual, who agreed that actually it was a really stupid thing to do and they wouldn't do it again. And it wasn't personal, it wasn't litigious, it was just a simple, this is the effect of what happened. We would have known about the patient hours earlier if the early warning score hadn't been modified to justify a respiratory rate of 70. So just to put some context around this, obviously our biggest competitor, I'll use that word lightly, is the National Early Warning Score in the UK. You can see the chart on the left-hand side doesn't have an area for modifications, and on the right, the only modification they've introduced is for patients who have chronic hypoxemia, for whom concerns over hypercapnic respiratory failure are high. So what they've done is introduced a standardized modification on their chart that has scale 1 or scale 2 on it. Now, again, they've done this after we've done our chart, but this is something we've since debated and felt that given we have the ability to modify on a per patient basis, we don't need a separate scale built into the chart that covers these patients. So the reason I've been asked is, are we going to change our chart to match theirs? The answer is no, because we were already ahead of the curve in having the ability to modify this. And also, I think under the red proviso, only under the direction of a qualified clinician, is difficult to interpret, because I find it hard, even as an ICU consultant, to work out who actually has true hypercapnic respiratory failure because of a hypoxic drive and who doesn't. And essentially, these are patients most likely restricted to a respiratory ward rather than anywhere else. So we didn't want to modify the entire chart for what are hopefully still a minority of patients. Alrighty, this is the final slide. Hopefully you're all still awake. Most of you seem to be. This is good. I'll keep going. So in summary, modifications are sometimes necessary, and I've accentuated sometimes because of the chart I showed you earlier. And the important part is the bold point. There is significant potential to cause harm by hiding sick patients or masking deterioration. And for that purpose, modifications should only be made by those who know what they're doing. The documentation for rationale is key because it stops doctors doing dumb things and provides accountability. But I hope there's one thing I've shown you: there is no right way to modify. And I know some of you maybe wanted some guidance around that, but all I can give you is expertise around having seen it done for a large period of time and what I think works for me and what works in my DHB, but completely recognizing may not work in yours. But I think the way to tighten that up is the last sentence, which is to audit it appropriately and bring bad modifications to your governance group. It may be that there's education around how this is done. When you start looking for problems and finding systemic issues, you may find particular individuals who are outliers who do dumb modifications and cause patients to deteriorate. The first thing I do whenever a patient is admitted acutely to the ward and I wasn't on call, to go acutely to ICU, is to go to their bed space and find their vital signs chart and look at the last 24 hours of vital signs and see what was modified. And it's not uncommon to find that these people have been hidden with modifications in place. And generally I will go either through our governance process, which is our resuscitation committee, or individually go and talk to individuals to try and stop this if they've ended up in ICU. Now, I'm aware I only see the ones where it doesn't work, because the ones where it do work get better and don't need to come to ICU. So I have a selective window on what I see. But I think governance is really key around this process, to make sure you audit and you find problems and solve them locally, rather than us saying this is how you would do it. Here's the template for all of you to do the same thing. Because if there's one thing I've learned from visiting pretty much all of you, it's that you are all very different in how you do things. And that's something that's really good, not really bad, because your circumstances are unique. And the last thing you need is a tertiary intensivist telling you what you're going to do because it works for him. It doesn't. You need solutions to your own problems, and that's what your governance committee is for. Right, that's me done talking. Thank you very much for listening. I hope some of that was useful and not too ranty.